everybody, and welcome to tonight's webinar. I'm excited to present Dr. Mackenzie Kelly to you. Housekeeping note, please put your questions in the Q&A and we will answer all of your questions at the end of the presentation. Dr. Mack, go for it.
Hello, everyone. Thank you so much for joining us tonight for the webinar titled From Observation to Action, Leveraging AI and Non-Invasive Therapies for Better Patient Outcomes. So I am your host tonight. I want to take a couple minutes to introduce myself and kind of explain why I get the honor of being able to communicate and present to you all this evening. My name is Dr. Mack. I practice in Denver, Colorado. I graduated from Indiana University about 10 years ago. Crazy to believe it's been 10 years now. Over the past 10 years, I have dedicated my life and a lot of my free time to advanced education. I have taken around 850, it might be around 900 hours of continuing education. I absolutely love learning. I try to go to a new course every single month if I can. Sometimes I travel away to go see the courses, or I attend online webinars like you all are learning tonight. I love education because it allows me to provide the best possible patient experience to my patients, and it allows me to interact with other colleagues. A lot of what I learn is from other colleagues, their best practices, what they find works best for them in their private practice or their clinical situation. So I think that's the most valuable part of these types of learning sessions. And I hope I am coming off as not intimidating and you feel that you can reach out to me via this online chat. I will answer questions at the end via our Q&A. I am a COIS Center graduate. I am very proud of being a COIS graduate. It's taken me about 5 years to finish the curriculum, and a lot of my philosophies and my evidence-based practice comes from the principles I've learned from COIS. In my free time, I love CrossFit, I love reading, and I love travel. And that is my cell phone number. So feel free to shoot me a text or a call if you have any questions after the end of this webinar. So these are some of my patients. Why am I showing you these photos? Because I am a practicing dentist. I am a practicing provider, just like you guys are all on this call. I don't speak for a living. I practice full time. And I'm showing you these pictures because these are all my patients. I am very, very passionate about minimally invasive dentistry and cosmetic dentistry. I'm showing you these photos because a lot of my patients come and find me because they want solutions. They want composite bonding, or they want prepless veneers because they don't want to remove any enamel. That's something that is very important to me, for them and for myself as well. So everything I do is all centered around minimally invasive dentistry. And so tonight I'm going to talk to you about a product that I have found super, super valuable in my practice. I am sponsored tonight by Vivardis. Thank you, Vivardis, for allowing me to speak to all of these participants tonight. But the reality is I was using this product way before I started to develop a professional relationship with Vivardis. Cool story. I was at a learning center. I was actually at an AACD conference, and I was talking in a group of colleagues about products that I found really, really like game changing in my practice. And one of the Vivardis reps came over to me and said, "Oh my gosh, you're so passionate about this. Like, do you mind talking to other dentists about how you use the product in your private practice?" And I'm like, "Absolutely, I'm happy to do so." Because the reality is, every one of us on this call probably has patients in our practice that we have been watching. And I know you guys probably have used that term before. If you're like me, used to do that all of the time. I would see a lesion on an x-ray. It would be a small, barely in through the enamel, and I would throw out that term. I'm just going to watch it. And why do we do that? Because we feel guilty drilling into enamel and removing tooth structure when a lesion is just barely through the enamel. There's kind of this gray area where if we showed the x-ray to a bunch of clinicians, some of us might say, hey, I want to intervene. I want to do a small, minimally invasive class 2 type restoration. Some of us would educate the patient about flossing better. Maybe we would do diet counseling. We would maybe look at maybe some elements of sleep because maybe they're mouth breathing. We might do some pH testing of their saliva. So the cavity process is multifactorial, but the reality is a lot of us probably on this call can agree that this gray area for these lesions prior to some of these advanced minimally invasive technologies, a lot of us didn't know what to do. And myself included, I would put a watch on these lesions. And I just felt like I was doing a disservice to my patients because the reality is a lot of these lesions are going to continue to get bigger. Patients rarely change their habits. They might come in for a cleaning and an exam and get really inspired, leave with their sample of floss and toothpaste, and they'll probably floss for about 2 weeks. And then when their sample runs out, they will stop flossing until a couple days before their next cleaning visit, and they'll just revert to their old habits. So the patients rarely change their habits, and we're missing an opportunity for intervention. I just felt like there was this unmet need. There was this gap in between what the patients presented with and what I was able to provide them in terms of a good service. So prior to me hearing about Curodont, I would put a watch on these areas and I would maybe recommend a prescription toothpaste such as Climpro or Prevident. Maybe I would use an over-the-counter toothpaste such as MI paste or something with hydroxyapatite. I would recommend flossing. I might tell them to put toothpaste on their floss to get into the interproximal areas. And I just kept seeing these lesions get bigger and bigger and bigger. And eventually it would reach a point in time where these lesions would hit the dentin and then it was time for me to intervene. So maybe I could do some oral hygiene instruction and try to delay the inevitable. But these lesions didn't ever get smaller. They just slowed down and I tried to drag it out as long as possible. And then I heard about this product called Curodont. And it was developed by a team out of Switzerland. And essentially it is a peptide formulation that diffuses into the enamel and it regrows hydroxyapatite. So cool. It's the product we've all been waiting for a really long time. I don't know if you have clients or patients in your office who just say, if they have some cavities, they say, oh my gosh, I'm waiting for the day when we can regrow teeth. I've had patients say that to me, we can regrow organs. I can't wait until we can regrow teeth. Well, in a way, this is a way of regrowing enamel. And so that's how I kind of explain it to my patients is we're going to regenerate your enamel via this solution that's going to penetrate into your enamel. It's going to form a scaffold, and then it's going to pull in the patient's own nutrients from their saliva, calcium and phosphate, and it's going to regenerate hydroxyapatite. So super, super cool. It's something that I have been waiting for my entire dental career. So it works a little bit differently than fluoride. If you start using it in your practice, or if I have hygienists on this call, you're going to be the ones who are probably talking or having the introduction to Curodont when your patient is in the chair. And the number one question you're going to get asked is, how is this different than fluoride? So I explain it to my patients like this. Fluoride is a surface prevention. It works on the top outer layer of the enamel and it works by creating a harder surface layer of enamel. Whereas Curodont actually penetrates to the depth of the lesion and regenerates hydroxyapatite from the inside out. So it can penetrate a lot deeper than fluoride can. So I'm going to show you a cool designation. So over here on the upper left, and I don't know if you can see my mouse or not, but this is superficial remineralization. So this is showing the fluoride. So fluoride works about 25 micrometers, so basically super superficial, whereas Curodont is actually able to penetrate up to 1,500 micrometers into the enamel. So you can regenerate a lesion all the way up until it hits the dentin. So it differs in fluoride in that sense. It's actually able to regenerate hydroxyapatite from the inside out. So benefits of Curodont. It is totally non-invasive. There are not many other adjunct therapies like this that are able to regenerate tooth structure that is totally non-invasive. And I will have a slide later on because a lot of clinicians and colleagues will ask me what is the difference between Curodont and Icon treatment, so something like a resin infiltration. So hold that question for later because I will get into the differences of that. But Curodont works a little bit differently than other treatments because it is totally non-invasive. There's no needles, there's no drilling. You just paint it on the enamel and it regenerates hydroxyapatite from the inside out. In my practice, it reduces my risk of no-shows. So you might think, well, how does that happen? Because we all know that patients sometimes lose insurance coverage, or you have a patient who's been coming to you every three months, 4 months, 6 months, then all of a sudden they lose insurance, or maybe they move away. Maybe they get pregnant and life gets crazy for a while. Their hormones change, their medical history changes. Maybe they get on a medication that changes their saliva, and all of a sudden you've had these lesions that in your head you were planning on watching. You're like, I'm just going to keep watching on this because I see this patient every 6 months. Then all of a sudden they fall off and you don't see them again for 2 or 3 years. They come back to your practice and all of a sudden they have lesions that blossomed and got a lot bigger than you were expected. And now you're going to need to jump in and do restorative dentistry. So to me, I would much rather treat that patient while they are in my chair because I don't know what's going to happen to them. I don't know if they're going to lose access to care, maybe by their fault or a fault that's not someone else's fault. And so I want to be able to manage them by being able to provide a same-day treatment. In terms of saving chair time, this is a no-brainer for me. Even if you're a fast clinician and you're able to get the patient numb very quickly, get them comfortable in the chair, do a really quick prep, isolate well, place your band and place your restoration. The reality is even placing a single unit filling is going to take us anywhere from 20 to 30 minutes. This product you can apply to the area and it takes 3 minutes. To me, that's a no-brainer. And that's taking into account the chair time for one restoration. The average lifespan of a restoration is around 11 years. So if you're doing a class 2 composite on a patient who's in their 20s or in their 30s, that restoration is going to need to be replaced again every 10-ish years on a good end. Maybe it is replaced every 15 years, maybe replaced every 5 years. But even if we're placing really, really good restorations, there is going to be some marginal breakdown and some leakage that occurs around the edge of the restoration, and it is going to need to be replaced. So over the time of that patient's life, that tooth is, it's not just that 20 minutes or 30 minutes of placing the restoration that first time. It's going to need to be replaced again and again and again. And every time we take out that restoration, it's going to become a bigger restoration. So, a class 2 composite in their 20s, maybe it's replaced in their 30s again, and then when they're 40, it turns into a crown. So, that chair time is long over the course of that patient's life, but also you're preventing that patient from needing to get more invasive treatment. So to me, the chair time and saving the patient's own enamel, it's just a win-win. We know that are these lesions that are small, if left untreated, are going to turn into bigger lesions, which can increase the risk of long-term problems. Maybe it becomes a larger lesion and ends up needing a root canal treatment. So by keeping the lesion small and treating it when it's still just barely through the enamel, we are allowing the patient to regrow their own enamel and thereby decreasing chance of long-term infection and bigger complications. But the number one reason why I use this product is because my patients love it. I don't know, I can't see all of your friendly faces on this call, but I'm guessing your patients are very similar to mine, and they don't willingly skip into the office excited to show up and get numb. No patient likes getting numb. No patient loves, maybe they like getting their teeth cleaned, but no patient likes getting numb. No one likes getting drilled in. They do it because they have to. They do it because we recommended a restoration. So my patients love this type of minimally invasive treatment because it saves them from needing dental work. Every time I go over the pros and cons to getting this type of treatment, believe it or not, they like sign up for it every single time, even though there's not as much insurance coverage. Usually the cost doesn't prevent them from getting this type of treatment. They still want it anyways. They love minimally invasive dentistry. So the key to success is finding lesions that are just through the enamel. You want to avoid lesions that are getting into the DEJ. Once the lesion has gotten into the DEJ, you have missed your window of opportunity. Now it needs to become a restoration. So I get that question a lot when I'm interacting with my colleagues. They say, hey, Curodont doesn't work for me. And I say, really? Can you show me the x-ray of what you tried to treat? And they show me a lesion that really would have benefited from a root canal. You guys, this is a great treatment, but it's not magic. You want to be able to select lesions that are just through the enamel, 25% of the way through the enamel, 75% of the way through the enamel, anywhere before it starts to involve the dentin. Once it involves the dentin, you need to do a restoration. You can use it on all types of lesions. So you can use it on facial white spot lesions. So while the patient is in ortho treatment, this is a great service for them. When they get their brackets off, you can apply this on the facial surfaces of demineralized teeth. You can apply it on occlusal surfaces. In my practice, I apply it the most in interproximal lesions. I see a lot of patients who are 25 to 45 years old. So just in my clientele, a lot of them need it in the interproximal areas the most, but you can absolutely use it on occlusal and facial surfaces as well. It works for all ages, regardless of their age and regardless of their oral hygiene habits. I will say a caveat. I still think it is very, very important to encourage your patient to brush and floss and monitor their sugar intake and monitor their acidity of their saliva. This isn't, like I said, this isn't magic. If they're not using good practices, they might start to develop other lesions in other areas of their mouth. So yes, I might apply it to this area, and I might say, hey, you want to make sure you're eating a healthy diet. You want to manage your sugar and your acidity intake. It is going to fix the area that I apply it to, but you might start to develop lesions in other areas of your mouth if you don't change your habits. So let me be clear. I do think it's very, very important to also manage the patient's oral hygiene in combination with using this type of product. This is just a tool in your toolbox. This is for using or remineralizing the areas that are already start to showing up on the x-rays. So, a quick diagram of lesions you want to be looking for. You want to look for lesions in this green box over here on the left-hand side. So you want to look for lesions that are just starting to get through the enamel, maybe just starting to begin to touch the enamel, but not yet involving the dentin. So these pictures over here on the right-hand side, these are areas that you would want to treat restoratively. How do I catch these types of lesions early? In my practice, I am using AI interpretation. I don't know how many of you on this call are utilizing AI interpretation. If you are not, I would highly recommend looking into it. There's a lot of computer software interpretations out there. In my practice, I use Pearl. I love Pearl. I've been using Pearl for about 2-ish years now. It helps me, it integrates into your X-ray software and it helps detect these lesions early. So I'm going to show you on the next couple slides what it looks like when it highlights these lesions. So it enables proactive care. Why do I personally use AI? Because it allows me to for the technology to be the bad guy. You know, I just put it up on the screen. Your x-rays are going to turn colors like this, and it's going to highlight areas of calculus. It's going to measure areas of bone loss. It is going to highlight and designate incipient lesions. So it'll have incipient lesions designated in yellow. It'll have lesions involving the dentin in pink. And you put up these x-rays with AI interpretation and the patients start to get curious. They're like, "Hey doctor, what's that pink up there? Hey doctor, what's that blue? What's that blue there in the center of the tooth?" I have this AI interpreted it into my x-rays, and I don't really have patients turn down x-rays anymore. It's honestly amazing. You know, maybe if they're a new patient to the practice, they might want to refer x-rays. My patients are probably very similar to yours. Doctor, I don't need x-rays. I had this this one PA taken of me 6 years ago. Won't that suffice? No, it won't. In my practice, I take a full set of x-rays within the first appointment, or if they're coming with another set of x-rays. But the reality is a lot of the x-rays that they get integrated from another office are sometimes blurry. Sometimes you can't read them. So a new patient exam for me always includes x-rays, and it allows us to have another point of communication. So the patients get curious, the hygienists on this call, I encourage you to start using AI if you already have it in your practice. It allows you to feel more confident. You know, you can highlight it on your x-rays. And you can say, "Look, I'm going to have the doctor come in and look. This area looks suspicious to me. I want to have them check it. They might recommend a restoration here in this area. I'll have them give the final call." And a big one for me is less insurance denials. I have a great work-life balance. I don't want to spend my extra time away from patient care writing letters to insurance. I hate insurance denials. So this allows me to back up my treatment recommendations. And I have found I am doing less insurance letters back and forth. I have less insurance denials, which is truly amazing. So this is what it looks like. Your incipient lesions on Pearl, at least. I don't have access to the other softwares out there, but there are several out there. Vidya is one, Overjet is another. So there are several X-ray softwares out there that I encourage you guys to look at. This is just the one that I use, so I have a lot of examples, but your lesions are going to be yellow if they're incipient, if they're just through the enamel. If they're into the dentin, they're going to be pink. Areas of tartar are going to show up in this green box. It's going to highlight open margins in purple. It will highlight radiolucencies in blue, and then it will designate different areas of bone loss in different colors. So it's kind of like a stoplight: green, yellow, and then red. So larger areas of bone loss are highlighted in red. That kind of draws your eye to it, and it allows more dialogue or more open dialogue with your patients. So here's another quick slide. This is kind of what they look like, but I want to show you some of my own slides. So these are some Pearl AI interpretation, and these are some of my before and afters with Curodont. So this is, before I show you some before and afters, this is a traditional X-ray on your left-hand side. And then this on the right-hand side is AI interpretation turned on. So you can toggle off the AI interpretation on or off, kind of dependent on your preferences. But essentially what I'll do is I'll have this x-ray pulled up and the patient will see all of these colors highlighted on the screen. You know, they're not used to seeing colors on an x-ray. They're very used to seeing these arbitrary black and white images. All of a sudden, when color starts to be highlighted on the images, they get curious. And so this is a patient who came to me for a second opinion. And the patient said, she was like a 35-year-old female. I can't remember the exact age, but she said, Doctor, I've never really had any cavities before. And I just went to a practice recently and they told me that I need 8 fillings. And so I had my assistant take a full set of x-rays on her. And we pulled the images up on the screen and literally the demeanor changes. And she goes, wow. So I really do need 8 fillings. And I said, well, you have 8 areas of decay, but that doesn't necessarily mean that you need 8 fillings. You see these areas in the yellow, we can actually treat those with a minimally invasive or a non-invasive treatment. I could do it for you right now. We paint it on your teeth. There's no numbing, there's no drilling, and it's going to regenerate your own enamel. Using a peptide formulation, and this area in the pink there that is larger into the dentin. So we actually need to do a restoration. And the patient goes, wow, that's amazing. Why didn't the other dentist recommend that? And I think it's really important that as dentists, we don't shame each other, or we don't, talk badly among one another. So I just said something like, maybe they're not familiar with that technology. I'm not quite sure. But this is what I do in my practice. Would you like to try? Yes or no? And it's amazing because the patient immediately is like, yes, I want to try that. So I do think it's important to, in my practice, I use other diagnosis modalities. You can use transillumination, you can use diagonal cam. So you can use other areas to almost back up your recommendations as well, not just AI. But this is a before and after on the top with just traditional x-ray. So no AI turned on. And you can see all these areas are kind of hard to see. You almost have to squint to look at them and see like, okay, is it there? Is it not there? And then this is before and after with AI interpretation on the bottom. So you can see all these lesions get much smaller, or the AI is no longer even able to pick them up. So that's really, really cool to see. And once the patients start to see that the area is getting smaller, you will be surprised that they start saying, wow, is there any other areas in my mouth that you need to apply this product to? They start wanting treatment. They start wanting x-rays. They start being proactive in their own care. It's honestly an amazing phenomenon that I've noticed in my practice. So this is another patient that I treated number 30 mesial and number 31 mesial. And you can see on the top half of the screen, the before and after. And you can see these lesions are somewhat difficult to see when the AI is not turned on, because you're really looking for lesions that are just kind of barely through the enamel. You don't want any really, really obvious lesions, because a lot of times when they're really obvious, it's time for a restoration, right? They're into the dentin, they're larger. So we want to be looking for these smaller lesions. So on the bottom here, you can see my AI interpretation turned on. These lesions are, maybe 75% of the way through the enamel. And then on the x-ray on the bottom, you can see with AI interpretation turned on, the lesions are no longer visible. So once you have patients start to see these type of results, you're going to have them start asking for more treatment. They're like, this is amazing. Thank you for providing this service. I don't have to get numb. This is amazing. This is great. Is there any other areas in my mouth where I need this? This is another lesion that I treated, number back-to-back kissing cavities, number 28 distal, number 29 mesial. And you can see that 1 year later, the lesions are no longer visible on the bottom of the screen here. So they are no longer being picked up by AI interpretation anymore. And without AI, they are just barely visible. This is another case here that I treated, number 13 mesial, 18 mesial, 19 distal, and number 20 distal. So this bottom picture, number 19 distal, is why I think it's still important to use adjunct therapies in order to confirm your diagnosis. Because you might be thinking, well, Dr. Mack, that lesion down there on number 19 distal is showing into the dentin. It's pink. Why did you treat that with Curodont? Because I used other modalities to be able to visualize how deep the lesion was into the enamel. And I was able to confirm with showing the x-rays from different angles that the lesion was not yet into dentin. So I felt it was appropriate to treat this area with Curodont. And you can see this lesion getting smaller. And now it's yellow. It might be halfway through the enamel, maybe 60% of the way through the enamel. The lesion on number 18 mesial is no longer visible. The lesion on number 13 mesial is still present, but maybe a little bit smaller. But that's the type of results that I have been seeing in my practice. It's truly been a game changer. In case any of you on this call use other AI interpretation, I wanted to include a couple borrowed slides from other clinicians. This X-ray is from Rebecca Pounds. I believe this is with Vidya. So she is showing some before and after on number 13 distal there, and you can see it, the lesions getting smaller. Same thing. I'm not sure the clinician on this case, so I apologize, but I just wanted to be able to provide a couple other x-rays from other clinicians using other imaging software. So these are a couple lesions that were treated in the upper left quadrant, and you can see them getting smaller on the right hand image on the right side. This is an image without AI. You can see it looks like some premolars and some molars treated on the patient's left-hand side. And you can see these lesions getting smaller after a 6-month time period. And in case I have any patients who have any, or in case I have any clinicians with patients who are currently in ortho or finished ortho, this is a case that was treated with Curodont. I do think it's important to note that the cosmetic results vary from patient to patient. It is very dependent on the depth of the demineralization and the patient's regeneration potential. So the visible results vary from patient to patient. I think it's important to not promise any specific cosmetic before and afters, but to me, this type of treatment differs from icon remineralization. I still use icon in my practice. I think it's a great service for patient. But what icon is doing is it's plugging up the pores, the porosities on the superficial aspect of the enamel, so that the light reflects off the enamel differently. So that allows it to have a different cosmetic result. Whereas Curodont actually regenerates, so it's a different like chemistry. It's actually changing the chemistry of the enamel. It's rebuilding enamel from the inside out. So if you were to extract the tooth and cut it down the middle and put it under a microscope, you would actually see the changes within the depth of the lesion. Whereas icon or any other type of superficial resin infiltration, you're only going to notice a change on the outer periphery, and it's only going to be a cosmetic change and not actually a biomimetic change throughout the depth of the demineralization. So these are some of my patients from this week. Actually, not this week anymore. This is an older slide, but a couple months ago. And I'm just going to go through how I use Pearl in my practice or AI interpretation in my practice. So I will always turn it on. Sometimes I toggle it on and off so I can get a better look at what the lesion looks like, but I'll just turn it on. And this is an older iteration of pearl back when all the lesions used to be pink. They were all pink. And so I was really easily able to communicate with my patients in this upper right slide, or this upper right image. Hey, this lesion on tooth number 30 is very closely approximating your nerve tissue. I'm going to attempt to do a restoration here, but there's a high chance that you might need endodontic therapy at the end of this restorative treatment. It allows me to educate the patient on the front end rather than making excuses on the back end. So I think that this is a really important adjunct therapy in order to recommend really easily different types of treatment. So you can say, hey, this area is smaller. A patient, even if they're not trained in interpreting x-rays, they're able to tell the difference in the size of the pink or the size of the yellow, and it makes sense to them. You know, they might not even be in the medical field, but they're able to see the differences in between this little teeny pink area versus a larger area versus a very small area, which you could say, hey, this area in this upper right here, I'm going to treat with a non-invasive treatment. There's no needles, there's no numbing. I'm going to apply it onto your tooth today if you would like, and your body is going to regenerate its own enamel. This lesion over here on the tooth right behind it is a little bit deeper, and they can actually see the difference between this deeper lesion and the one next to it that is smaller. They can understand why you're recommending a filling in one spot versus a non-invasive modality such as Curodont in a different spot. So these are a couple other before and after I included because this is Soda Cloud. So this is if you're using a cloud-based imaging software such as Soda, this is what your images might look like. So this is an area I treated 6 months later, number 29 distal, and you can see the lesion getting smaller over time. And then this is another lesion that I treated without x-ray interpretation, because I know some of you on this call might not have AI integrated yet. So this is number 5 distal, and this is a really common type of before and after that I see in my practice. Number 5 lesion almost getting close to the dentin, and then about 1 year later, the lesion significantly getting much smaller. Let's see what we treated here. This is number 3 mesial and number 30 mesial. So you can see in the upper left-hand side about the lesion about halfway through the enamel. And then on this right side image, it's just a little blip. So it becomes a lot smaller. Same thing with tooth number 30. You're looking for these lesions that are maybe 75% of the way through the enamel. And then the lesion is much smaller 1 year later. So an important thing to note is just because you can't see it on the x-ray does not mean that hydroxyapatite wasn't generated. So this was an important study conducted by dental advisors, and they actually took teeth and they looked at them under a microscope, and they saw hydroxyapatite being regenerated all the way to the depth of the lesion within 2 weeks. So it is able to regenerate, but the time at which it starts to become visible, the visible changes, is different from patient to patient. That it depends on the patient's chemistry within their saliva, their regeneration potential, how much hydroxyapatite has been regenerated. It's a lot of things come into play there. And when I have a patient ask me questions or a hygienist ask me questions about, hey, did this work or not? I kind of use the analogy that endodontists use, that when there is a periapical radiolucency and the patient has been treated with root canal therapy, you see the lesion getting smaller over time, but the bone might not be 100% bone fill immediately after the root canal treatment. It takes a while to show radiographic changes. So the same is consistent with remineralizing potential of Curodont treatment. How do we apply Curodont? If you're looking to get into this, it's super easy to do. You are going to open up the packet. It comes in a sponge and a liquid dispenser. You are going to open up the sponge, apply a couple drops of the liquid into the sponge, and you're going to let it sit there for 2 minutes. While you are doing this, you're going to clean the area. So you use pumice to remove the biofilm from the patient's tooth surface that you're wanting to treat. And then you're going to etch the surface. So you're going to apply etch to the interproximal area or the facial surface or the occlusal surface. And you're going to use floss to get that etch into the interproximal area. And then you're going to rinse and dry. You isolate the area super easily with cotton rolls. You need to use an isolate. You don't need to rubber dam the area. It's super, super easy to isolate. And then you're just going to take that sponge that's been sitting there on your countertop for 2 minutes, and you're going to apply it to the surface that you're wanting to treat. So either the interproximal area or the facial surface or the occlusal surface. That sponge is good for one treatment site. So of course, if you're treating back-to-back lesions, you're automatically going to be treating both lesions automatically. But if you're going to apply to one interproximal surface and then you're wanting to treat the other interproximal surface of that same tooth, you really need to open up 2 packets, because 90% of that product is going to get absorbed immediately with that sponge into that first point of contact. So if you keep using that sponge into subsequent areas of that quadrant, you're not going to get as much product into the second and third and fourth application site. So it's really important, if you're going to be treating multiple areas, open up a couple different product or packets in order to get the product where it needs to go. The post-op is super easy. It's pretty much the same post-op instructions that you would use for fluoride: no spitting, no rinsing, no eating for 30 minutes. You really want to allow the patient the opportunity for the saliva to absorb and the nutrients to absorb into the enamel surface. You don't want to immediately drink a coffee or drink water or something else that's going to dilute the product. So just tell them to avoid drinking or eating for 30 minutes. But other than that, it's super, super easy. It doesn't feel like fluoride, it feels like water. So they will literally be able to tell no differences. That it doesn't feel sticky or slimy or waxy like fluoride does. A couple common questions I get: if you're applying to an interproximal area, do you have to separate the teeth with wedges or an instrument? No, you do not have to do that. The floss is able to pull the etch into the interproximal area. That's all you need to do, is just floss the interproximal area. You do not need to use separators or wedges. How do I use it in my practice? I have my hygienist apply it for me. I empower my hygiene team to start having that conversation when the patient is in the chair for their hygiene recare visit. I think that there's no better time that the hygienist has the images pulled up on the screen. They're the ones who are cleaning the area and removing all the biofilm. So my workflow kind of goes like this. My hygienist we use radios in my office. They'll say, "Dr. Mack, I've identified a couple spots for Curodont. Can you please stop in when you get a second?" And either at a good stopping point, I'll take my gloves off, I'll go get up, I'll do my exam and say, "Yes, that's a great spots. I confirm diagnosis. Those are excellent spots for treatment with Curodont. Go ahead and apply the treatment." If I'm not at a good stopping point, I will pull up the x-rays in my operatory where I'm working, and I'll radio back and say, "Yes, that looks great. I'm confirming diagnosis. I'll be in shortly. Go ahead and apply the Curodont," because that's a great time for the hygienist to apply the Curodont when they're waiting for an exam. You know, they're sitting there, they're waiting for an exam, they're waiting for the dentist to get up and have a good stopping point. There's no better time. For me, I love this because I am a good dentist, but I hate class 2s. I don't want to be doing class 2s. I don't know how many of you are on this call who love class 2s, but I don't meet many dentists who love class 2 restorations. They're a pain in the butt. They're low ROI. You have to do them because the patient needs them. But I would much rather be doing quadrant dentistry. I want to be doing quadrant dentistry. I like cosmetic dentistry. I want to be focusing my efforts on smile designs and full mouth rehabs. I don't really want to spend my time doing small lesions. So to me, I get this question or comment a lot, Dr. Mack, aren't you worried that it's going to take away revenue from you? No, I'm not, because we're still getting the same ROI for that tooth. In my practice, I'm charging around 120 per tooth. That's like the same amount that I would get for a filling after insurance write-off. So, and it's easier, it's less chair time. So to me, it's a no-brainer. I would much rather do this. It's better for the patient. It saves enamel. It saves chair time, and you're still getting the same ROI in terms of revenue generated. So I'm just slipping through these slides due to lack of time. I want to make sure we have time for question and answers. Utilizing Pearl, you can identify in Huddle spots that you think you might be able to do cured on in advance. So in my practice, I'm using the Pearl intelligence software, and it is able to tell me areas where it is thinking that a incipient lesion might be present. So my hygienists are going through their patients for the day, and they're saying, hey, this predicted column over here on the right hand side, it will predict maybe a restoration is needed. Maybe an incipient lesion is present. So it's predicting that you might need to place a treatment such as Curodont. So it's super, super helpful. That's how we identify these lesions in advance. But ideally, if it's picking up on lesions that are incipient, I hope that you treated them last time. I hope that you treated them when they were in your office the time before, when they were getting the x-rays done. There's no better time than doing the lesion when the lesion is first identified and the patient is in the chair. So these are a couple of the phrases that I use for when I'm talking about Curodont. A lot of times my hygienists are the ones bringing it up, and I'm coming in to back them up for treatment. But these are a couple phrases that I use. Feel free to take a picture or a screenshot of the slide. But this is how I talk to my patients. You have a small cavity that I can treat with Curodont. It's drill free and needle free. It only takes 3 minutes. Do you want to do it? Yes or no? They can say no. Don't feel like you have to force them into this treatment. They can always say no. But I think it's important for us to provide the option for these patients because they might want this type of treatment. Insurance coverage varies. We can treat now and preserve your natural tooth structure without drilling. Do you want to try? And we can treat same day, right now. As soon as you're done with your cleaning, I can apply it to your tooth. Do you want to do this? A quick difference between resin infiltration and Curodont. Once again, resin infiltration is micro-invasive. Like I said earlier on in this presentation, I do icon treatment. I think it's a great treatment modality for patients who have white spot lesions. But it's important to designate and notate the differences. The indication for resin infiltration is more cosmetic, whereas the Curodont, it's more demineralized enamel because with resin infiltration, you're actually occluding the porosities and you're changing the surface, the way that the light reflects off the surface of the enamel. Whereas with Curodont, you're actually repairing enamel. You're actually rebuilding the hydroxyapatite from the inside out. The number one reason too what the difference is for me is the working time. Icon treatment takes me about 45 minutes to apply. I have to isolate really well. In my practice, it is a doctor-led treatment. Whereas with Curodont, your assistant or your hygienist can do it for you and it takes 3 minutes. So that's the biggest difference for me and the number one reason why I would choose Curodont over something like resin infiltration. Um, I really hope that you leave here tonight with a change in your mindset. There is really nothing to lose by doing minimally invasive dentistry. It has a very, very high success rate. In my practice, I've noticed higher than 90% success rate. The third party and separate research groups that have tested this product have noticed an over 90% success rate with this treatment. And I sometimes have clinicians come and tell me, well, what happens when it doesn't work? Well, when it doesn't work, which is not very often, you're right back at square one. You're right back at square one where you were just watching it anyways. You were watching and doing nothing. So if it doesn't work, maybe it's time for a restoration, but at least you tried to allow the patient to regenerate their own enamel. So, I really hope that with this call, you are motivated to start changing the mindset of your teams. I hope that you start offering minimally and non-invasive treatments to your patients because they will want this type of treatment. I have a super, super high amount of patients who say yes to this treatment, and it's just totally been a game changer for my practice. With that, I am going to, really quick, if you do have questions or want more information, I really encourage you guys to visit the Vivardis website. There are a ton of scientific articles listed on the Vivardis website that are from third-party research groups, so separate research groups. So I really, really encourage you guys to check out the information and research if you have questions. With that, here is my contact information. I am going to open it up for question and answer.
Thank you so much, Dr. Mack. I have a couple questions that I answered in the chat during the meeting. I'm going to read those out really quickly. How much does this cost? We are direct with Henry Schein, so please contact your Henry Schein representative for a price. Can you utilize as full mouth preventive treatment? No, this is not a prevention. This is a treatment, and it requires that low pH, that actual caries process to work. Would this have any effect on genetic white spot lesions? Again, no, it requires that caries process. Can this be applied by a hygienist? This is state dependent, y'all. So some states FDAs and assistants can place, some states hygiene can place. It's completely dependent on the state that you're practicing in. Can this be used on white spot lesions that are a few years old? It's only for active lesions. So if it's already remineralized and smooth, Curodont is not going to be the way to go. Dr. Mack, some questions for you. Can this be applied around restorations to help extend the life of restorations?
No. No, super common question. I've been asked this every single time. No, if you see recurrent decay under a restoration, or you see a poor, like ill-fitting restoration where you have leakage, that is not a good place to place Curodont. You really want to start looking for these incipient lesions. I think when there's a margin available, there's just way too many extra factors involved. That's an area for bacteria to harbor. I don't think that that's a good spot to try, and it's not a clinical indication for this product.
Thank you. What happens if you place Curodont on cementum? Is it an appropriate liner for direct composites?
No. No, it is used on enamel surfaces only, so not cementum. It is for enamel smooth surfaces only, and it is not for a liner. If you were using it as a liner, I'm guessing the restoration, you would be, placing a restoration and you would be into the dentin service. This is not a clinical indication for Curodont. You do not want to use this as a liner for your restorations.
Is the white chalky lesion going to disappear over time?
I have found it, yes, disappear over time, but it really depends patient to patient. So it's dependent on how much demineralization is present. It is dependent on the remineralization potential of that patient. So how much calcium and phosphate they have in their saliva, their current oral hygiene, their diet factors. So I never promise any cosmetic before and afters, I say this is an outcome that we are hoping for, but we're really hoping for a change in the chemistry of the enamel itself. We really are hoping for an actual rebuilding of the enamel, not as much cosmetic.
Okay. If the lesion does not heal or is still present, do you retreat and when?
I have this question a lot. I typically don't because I have found that as I follow these lesions over time, if you give it enough time, they continue to get smaller and smaller over time. I've found that the lesion totally regenerates in 6 months sometimes. In some patients, it regenerates in 18 months. It really is patient to patient. I have patients where it's getting smaller and they ask for it. And I personally see no reason to not apply it again. If they're asking for it and I say, we don't really have to, I will have patients say, but I want to do everything I can to eliminate the chance of a restoration. Can I have it? Well, of course you can. I'm going to apply it then. But I found that over time they continue to get smaller and I feel there's no reason to retreat.
How do you bill to insurance?
I am personally not in network with a lot of insurance, and I find that insurance coverage varies state to state, and insurance reimburses varies state to state. So I personally bill the patient, and I think the nation average for billing out for this the cost is anywhere from $100 to $150 per site. I personally charge $120 per site. And I phrase it to the patient like, hey, I'm gonna charge you. This is your out-of-pocket cost. If you want to attempt to get reimbursement from your own insurance carrier, you are welcome to do that. The code I put in the patient's chart is D2991. And Amanda, maybe do you feel that my wording, that you find many clinicians saying that same wording to you?
Yes. Yes. And we're seeing, anywhere from 50 to 60% of private insurances covering this. There's also Medicaid coverage by
Yes.
state. So please check with your Medicaid coverage.
Yes.
One I want to address really quickly. One application, y'all, is for one lesion. You cannot spread this over 3 or 4 teeth. This question is asking if they can spread it over 3 or 4 teeth. No, one sponge is for one lesion. We've got a few more. We've got about 15 more questions, so I'm going to go kind of quick. Let's see. After you place, how long do you wait for follow-up? And yeah, follow-up.
So I don't usually have like regular follow-up. I just send them on their way and I see them back for a recare visit depending on their patient's individual recare schedule. I have a lot of patients who ask for an x-ray at the 6 month mark, and I have no problem taking an x-ray to monitor the area and just see. I don't really think that you have to do that, but if the patient's asking for an x-ray, I do it. I don't bill out the insurance if I'm taking x-rays outside of the normal standard window. But a lot of times I provide it just as an adjunct therapy for the patient, and I see it getting smaller, and then they get super motivated to treat other areas if there are other areas that are needing to be treated.
Okay. For the ortho example with 8 and 9, if Curodont doesn't completely fix the white spot lesion cosmetically, can icon be used later?
Yes, great question. Yes, because your Curodont is penetrating and actually rebuilding hydroxyapatite from the inside out and changing the inner aspect of the enamel. If you still want a better benefit, like a more cosmetic benefit for the patient, you can use Icon afterwards. There's no contraindication for doing so.
Have you used blue check to identify hypomineralized areas to apply Curodont?
Yes, you can.
Have you treated a lesion and then restored it because of progression?
I don't think so yet. No.
Love that. Is Curodont floss into the inner prox area? No, Only the etch is flossed interproximally.
Mhm.
Can you share the difference between SDF, Curodont, and Icon?
SDF, I know that they're making clear versions of it now, but number one, it stains the teeth. So I don't like SDF as a modality. I don't see a lot of kids. I don't see a lot of elderly population. I still think SDF is an extremely important treatment option for a lot of patients. But a lot of times we're using SDF in areas of large decay to get it to slow down or try to get it to arrest. It changes the tooth black. Curodont is actually rebuilding the enamel for like more superficial type lesions, and it's totally clear, so you're not going to have any black or any chemical staining afterwards.
Beautiful. I'm going to just rapid fire a couple of these. Can we put fluoride on right after Curodont? Yes, you
Yes,
can place varnish. Can it be used on primary teeth?
yes,
How much do you charge for this procedure?
120.
Are the radiographs you showed after just one application?
Yes,
Beautiful. And just so y'all know, all of our research and cases are one-time application. Can this be used in conjunction with MI paste?
yes. Actually, I think it's great because MI paste has calcium and phosphate in it, so that's going to help the regeneration potential. So yes, do that.
Love it. And last but not least, I can tackle this one if you want, Dr. Matt. Can you explain why to use the sponge on one location instead of using it on multiple locations?
Yeah, you go. You'll be faster.
Okay. Each sponge is specifically measured to have enough effective, adequate dose for one lesion. One lesion is one smooth surface, one occlusal surface, or an interproximal area that can have up to two kissing cavities.
All right.
Awesome. We did it. Thanks,
We
Dr.
did.
Mack.
You're welcome. Reach out to me if you have questions. It's been great. I put my contact information on that last slide. I don't know if the people can see it or not, but the
They should
participants,
be able
but
to. I can
yeah,
still see it. Yep.
yeah. Reach out to me if you have
Awesome.
questions. Thank you.
Thank y'all. Have a good
Mhm.
night.